Good morning, everyone. My name is Clement Guede. I'm a senior member or professor at the Moffitt Cancer Center. And in my role today as the president-elect for AACE, I'm delighted to co-host this Zoom meeting with Dr. Charles Moore, who will introduce himself as well. Today's engagement lounge is entitled, as you can see on the slide, using cancer education to address social determinants of health in the era of COVID-19. What we hope today is to achieve both engagement of you all and hear your experiences as to how COVID-19 has affected your activities in cancer education. And these lounges are intended to be interactive sessions, Zoom meetings that are focusing on topics that are relevant to you today in the era of the pandemic. So we need to hear your voices, your ideas, and how you have managed and adjusted to this new situation and how you are going to move forward. The other piece of this is that we are going to have some polls in between. So we need your participation, and those will guide our conversations. So let me also say that we are delighted that this webinar or Zoom meeting is also co-sponsored by the AACE Membership Committee in conjunction with the Emory University Urban Health Initiative that Dr. Charles Moore directs. So he's going to introduce himself now.
Good morning, everyone. Thank you for joining us today. As Clement said, my name is Dr. Charles Moore. I am a past president of the AACE and also currently the director of the Urban Health Initiative at Emory and a professor at Emory University. Just to tell you a little bit about the Emory University Urban Health Initiative, our mission is to provide health disparities education and advocacy, build collaborative partnerships, and develop best practice models with low resource communities and those who work with them to advance equity in health and well-being. So the Emory University Urban Health Initiative is extraordinarily pleased to co-sponsor this event, and we look forward to hearing what is said today.
Okay. Thank you, Dr. Charles Moore. So our agenda today is we're going to have an initial discussion on COVID impact in our work, and I'll facilitate that portion. And then we'll transition to a second portion where we want to deal with social determinants and how they have impacted nationwide, and have a dialogue with Dr. Warren, facilitated by Dr. Charles Moore. So those are the two parts of our agenda. Before we go, we want to hear some ground rules from our manager and CEO of our management company in terms of our AACE, and Jennifer Luisi, who will tell us the rules for the day.
Hi, everyone. And I'm going to go away after this. I'll be off camera because you don't need to see me. I'm not contributing to the discussion. But our rules of engagement, please rename yourself if you need to, if it's not your name that is represented on the screen. Sometimes it picks up your device's name or your spouse's name or your kid's name. So if you need to, give us a name so that we know who to call on. If you want to speak out loud and unmute yourself, you can raise your hand. If you click on the participants window, there's an option to raise your hand at the bottom of that. And there are also other icons that you can click on if you feel the need to. If you want to type a response, please feel free to use the chat window. You can chat to everyone, and we'll be monitoring the chats for technical questions as well as for contributions to the discussion. We do have several polls, as Clement mentioned. They will not work if you are not using Zoom in an app or in the software that's downloaded on your computer. If you are in a browser, you won't be able to participate in the polls, just so you know. Technical issues, you can chat privately to me or to Sarah Ray, actually. And we are recording this session, so be aware of that before you speak up. If you are willing, we would love for you to turn your camera on so that we can see everybody's face, particularly when you're talking or contributing to the discussion. It's not a requirement, but it's just a nice thing that makes us able to see each other's face. So I'm going to stop the sharing now so we can see more faces and let everyone get on with it.
Okay, thank you, Jen. Can you launch the first poll? So for this poll, please answer the questions according to what you are seeing on your screen. And we have about 20 seconds, so act fast. Okay. So I don't know what you can see. Are you able to see the results of the poll? Okay, so I see some nodes. So as it turns out, it looks like most people have moved everything to virtual, 41%. About 29% have a combination, and about a third have canceled everything totally. So with those results in mind, we want now to hear from you again, remembering that 40% have moved everything to virtual, and a third have either a combination or totally canceled. So in thinking about your cancer education activities that are not training, because we covered training at the last webinar, we want to think about outreach, education, research in communities or with patient education. Can we begin to have a dialogue? Anyone can please chime in, talk about your experience, what you have done so far to mitigate, and how in giving us details, as well as how you think you will move forward. Unmute yourself and chime in. Okay. Has anybody, for those who have moved everything to virtual, how are you doing it? Jen, I still see people muted. I can't quite tell how they self-unmute.
They should just be able to push the mute unmute button down in the corner of their screen, but if they're having trouble with it, they can also raise their hand and I can try to unmute them.
Okay.
Hi, this is Michelle. So I'm currently conducting research with breast cancer survivors, and the part that I'm in now is focus groups. And so I've decided to do the focus groups virtually. And then it's going to be very interesting to see how this works out, because it will be including older women who might not be familiar with technology. One of the things that we did, we screened women to see if they are familiar with Zoom, if they've used Zoom before, if they have a tablet or a phone that they can use. And some of our participants haven't used Zoom before. So it's going to be interesting to see how it works out.
Thank you for sharing that experience. And as people talk, yeah, you should also share what surprised you and are you able to reach the same audience you used to reach by the previous method? Any other experience?
Hello, can you hear me?
Yes.
Hi, so my name is Elia Poulos and I work at the U Chicago Cancer Center. We have moved most of our programming to the Zoom format as well. And we do have some of those same challenges where there are some barriers to Zoom for people who aren't sure, you know, how it works, especially older people that we try to reach. And then we also have the issue of people experiencing some Zoom burnout, right? There's a lot of webinars are all sort of conducted in more or less the same format. So how do we think of new and engaging ways to use that, considering it's really our only platform that we have?
Yeah. And what other remedies are you using to reach those older folks? And are you simply not doing programs for them?
So we work a lot with partner organizations to try to reach them, and we've put together a Zoom like how-to guide that starts with, you know, what is Zoom, and, you know, works from there about how to download it and do all that. And we also have a team member who's putting together just a digital divide resource list in general, both to help community members and community organizations who are sort of thrown into this, where they need to use tech and maybe can't necessarily access it.
Thank you. Others? So has anyone looked at their data to analyze the demographics of the audience they are reaching with these alternative methods? What other experiences have others that are maybe different or similar to what has already been said so far?
Hey there, this is Natasha. Can you guys hear me?
Yes.
So I'm not currently doing research, cancer research, but I am doing community work and reaching seniors. The other speaker was just talking about seniors and not being able to use Zoom and electronics, but we're still, in reaching seniors, we're still doing things a little bit the old-fashioned way by actually calling them and talking to them on the phone, having a conversation with them. We're finding that that's a little bit more effective in reaching some of our senior community.
Thank you, Natasha. And for this session, we want to hear everything from community education, outreach, engagement, research in the outreach sense, like those who are doing screen to save, for example. I'm going to call on some people from my own institution, what alternative methods we are doing, and then be thinking whether you can speak to the question, are we still able to reach everyone, or is someone else being left behind? So let's hear more of the experience. So I'm gonna call upon Kalia. Could you speak to some of the challenges that you have seen so far?
Yes, can everyone hear me?
Yes.
Thank you, Dr. Guede. And so as we think about operationalizing this, we do have a project called Screen to Save, which is really focused on in-person colorectal cancer education with linkages to appropriate fit kit dissemination and colonoscopy referrals. And we're working with our clinic partners to help actually operationalize and implement this. Obviously, that was before COVID-19 came into the picture. So we have been discussing and along these lines, as well as our clinical trials option with doing a virtual option. We're in the initial phases of discussing perhaps what virtual recruitment would look like, or even a virtual session to conduct these educational colorectal cancer presentations. But because it was rooted heavily in actual in-person, some of that work was halted due to the coronavirus. And so we've had to take a step back and kind of assess what will work, what hasn't worked, and who may be left out, relying too heavily or relying only on the virtual aspect.
Thank you, Kalia. Any other experiences? Please unmute yourself at Lib.
I'd like to, Clement, it's James Marmee, and I'd like to ask a question to the floor, if I may. I'm wondering how people are preparing themselves for the longer term. If people are preparing for, given that we may have COVID with us for a long time, are people changing their structures with a view looking forward to 1 year, to 2 years, about how they'll affect their longer term delivery?
Thank you, James.
That's a good question. I'm a proud recipient of one of the ACE READS grants, and the grant is developed education program, a screening education program that's intended to be delivered in person. So that's exactly what I've been thinking about, like how can this be adapted in this climate? So that's definitely a thing that I'm considering now. And I'm welcome to any suggestions about that.
Hi, this is Nicole Bell with the Leukemia and Lymphoma Society. We've really shifted over to a virtual format even for all of our live programming, and plan to do that through the fall for the most part. You know, one of the things that we struggled with is the fact that we want to still make sure that our programs are somewhat intimate, because when we do live education programs in our smaller populations, you know, you get 20 to 50 people. So we're really working with the platform, either Zoom or whatever virtual company we go with, to make sure we try to still kind of have that intimate feeling so people can raise their hands and ask questions and have good conversation. We're just starting this now, so I don't have any outcomes, but hopefully it'll work for our constituents.
Thanks for sharing.
Jen, this may be a good time to do a second poll and ask the one that is really, I think it's poll number 2. And while she's doing that, I'm trying to look at, yeah, go ahead. So poll number 2 is up. Okay, so here are the results. As you can see, about a third or a little over, when we combine it, people are saying they have a planned first approach, which is about 12%, and or are implementing virtual options only for the meantime. And then the largest category is one that has not finalized plans and are still planning and talking through what adjustments they will make. So there's a lot of uncertainty, as we can see. So James' question, I think, is very pertinent, and we want to continue in the context of these results. What are some of the challenges for those that have not finalized plans? What are you thinking? What are the challenges that you are wrestling with?
Hi, this is Suzanne Pegan from Moffitt Cancer Center. I think there's a number of challenges we face going forward. I know for us, we do a lot of community interaction with individuals who are at risk or underserved. And I think one of the largest challenges about cancer education and screening education coming up is that this may not be the first priority for a lot of people who we would normally be reaching out to. Job security, you know, where are they getting their money, where are they getting their food, where are they sleeping, is something that is at the forefront of their thought process right now. And that's one of a few different challenges that we see coming down, but just wanted to say that.
Thank you. Other perspectives?
There are a couple in chat. We've got a question and also a comment in the chat window that might be helpful to read aloud, particularly for our recording.
Yes. So I see I'm gonna start with the chat above, maybe two above. So for those of you who are either practitioners or community outreach focused, what are some of the best practices that you want to see implemented in this time frame, in this era of COVID-19, or that you're already doing that you think ought to be shared with the group? What would you like to see happen going forward? What are you doing going forward? What would you like to share going forward?
It's Nicole again with LLS. Just in terms of touching base with people, we've recruited volunteers. We always have volunteers, but recruited our volunteers and doing a lot more check-ins with our patients, just calling to check in and see how they're doing, or just listening for the most part. But like y'all talked about earlier, you have a lot of people that don't have access to computers, et cetera. So we've done a lot of phone calls just to check in.
Mm-hmm. So one of the things that is sort of emerging here with this group that is waiting to see, there's a lot of uncertainty. But if we look at that categories, and part of what I'm seeing on the chat feature here is that folks are thinking, we don't know what outreach is going to look like, what PPE measures we need to implement in our community, in our own program here at the Moffitt Cancer Center. We are very much going through this dialogue as we speak in terms of when is it appropriate to send our teams out into the community? What protective equipment should they be wearing? What should they be asking community members about their own exposures? So we are sort of in that waiting period where we need to know a little bit more about what works and what is acceptable to communities. And I think it has been said, is this even a right time to be resuming cancer education? People thinking about screening and early detection of cancer, things of that nature. So how do we move forward from here? What can we share that when people get off this Zoom call, they might start to think about their own resuming?
Hi, this is Natasha again. Just some thoughts. I know we don't know what's going to happen, and that really our structure and the way we plan and decide what to do, it's going to depend on a lot of other variables. But I've been watching things on the news, as we all have, of people, creative things. There was a creative high school graduation yesterday, and there's one going on today where it's a parade kind of a graduation at one of the universities. Now, I know we can't do that particularly with research, but I'm thinking about whether or not when we send out outreach workers, once we know right now we know they need to wear a mask. We're not sure how safe they're going to be, but I'm wondering about the possibility of just doing those personal visits that are distant. You stand out so far away from the house and talk to a person on their porch or at their front door or that kind of thing. And it's a little bit more of a personal touch, particularly when we're talking about reaching elderly people, as opposed to trying to reach them on the via technology.
Yeah. So technology is the ultimate in social distancing, right? But what other harm may we be introducing in terms of disparities?
Well, we're leaving people out. Not everyone has a computer at their disposal. More people have phones than computers, but even those are not necessarily able to tap into the Zoom or other things like that, or have the knowledge or understanding. I have a couple of groups that I meet with on a regular basis, and we have a few people in a group that have not been meeting with us because we're meeting by Zoom, and they have such a difficult time with it. They're choosing not to meet until, you know, we're able to get back together again. So I do believe that there are people that are going to be left out. So we have to find some kind of creative way of reaching those people.
Okay. So as we transition to the next section, can we comment on anyone who has looked at their own data? Maybe it's too early because this all started in March. Maybe I'm asking an aspirational question, but I want to hear from anyone who has done something to address this potential introduction of the gap or a widening of the technology gap. Or even ideas how we might guard against that.
Sorry, this is Michelle again. One of the things that I had thought about doing for my study with the women in rural communities, or women, like you mentioned, Natasha, not having access to technology, is sharing an iPad, like, you know, research iPad that I have. I could send it to them, but then I think that this adds in a whole bunch of more logistic issues. But it's just something that I was thinking, you know, to be able to decrease that gap, because we were, like I mentioned, when we were screening for including women in the focus group, of course, we had to exclude some women who didn't have the access to the technology or available at a specific time. So that was one thing I considered, you know, being able to just send them an iPad and have them send it back to me once they're finished.
Thank you, Michelle. What concerns do we have about decontamination and all that stuff of the devices?
Right, exactly. There's so many logistical issues. I didn't think it was going to be a viable option.
Other experiences going forward, how we might help reduce the gap or address the ensuring we are broadly reaching the audience that needs to be reached? Okay, so I'm gonna do some summary comments here, then we can move to our next section of the lounge. So we've heard, based on this data, that many people, at least a third, have moved to a combination of virtual and other approaches to try to continue their work, whether it's cancer research outreach, education, patient education, and other practice settings. But we also heard, based on the second poll, that many have not finalized their plans for moving forward. I think this is really an opportunity for us to share, for those who have already addressed this, how it's working, what are the challenges, and what we might need to be thinking about, again, with a lens on trying to address that we remain inclusive and reach the audiences we intended or we were reaching before, so we don't introduce any new disparities. On that note, we're gonna transition to our next section, and we'll begin with a poll that Jen is gonna launch, and Dr. Charles Moore is going to do the facilitation of the next session. Jen.
Thanks, Dr. Guede. If everyone could take a few moments to answer this poll. The poll is continuing to rapidly change. And it appears that from this poll that 78% have 79% have chosen health disparities and health equity among underserved populations, followed by social and economic conditions and technologies and multimedia at 47%. Physical and social environmental conditions is 34%. And global cancer education and international collaboration is 6%. And none is other. So as you think about that, about your choices here, we'll be hearing from Dr. Reuben Warren. And at the end of his presentation, I hope that you'll come back to this question and help you formulate some additional questions. But I'd like to just introduce him a little bit more to you. Dr. Warren earned his undergraduate degree from San Francisco State University and a dental degree from Meharry Medical College. Subsequently, he completed both master's and doctorate degrees from the Harvard School of Public Health, as well as a 2-year residency at the Harvard School of Dental Medicine and Dental Public Health. Dr. Warren also completed a Master of Divinity from the Interdenominational Theological Center with a concentration in theology and ethics, and served as director of the Institute of Faith Health Leadership and as an adjunct professor of public health, medicine, and ethics at the Interdenominational Theological Center. Dr. Warren has had an illustrious career and has served as the Associate Director for Minority Health at the Center for Disease Control and Prevention, and as Associate Director for Urban Affairs at the Agency for Toxic Substances Diseases Registry. He was formerly the part-time Director of Infrastructure Development for the National Center on Minority Health and Health Disparities at the National Institutes of Health in Bethesda, Maryland, and as Associate Director for Environmental Justice, and worked at the National Center for Environmental Health in Atlanta, where he led the agency responsibility for environmental justice and minority health. He is currently the director of the National Center for Bioethics and Research in Healthcare and professor of bioethics at Tuskegee University in Tuskegee, Alabama. As you can see from his extensive public health experience at the community, state, local, national, and international levels, and as many of you have seen from his recent article in conjunction with Dr. Braithwaite, the article titled "The African American Petri Dish," there is no one better suited to lead the next portion of the AACE Emory Urban Health Initiative Lounge focused on racial disparities from COVID-19. So without further ado, I present to you Dr. Reuben Warren.
Good afternoon, and it's always a pleasure to do anything with Dr. Moore. I had a really good time last year with AACE, and I've been working with the Urban Health Initiative at Emory for several years. It is an exciting opportunity. And again, I'm honored to really share a few of my thoughts with you. As Dr. Moore indicated, I have been working in public health ethics for last 10 or 12 years in official capacity, but I think all of my career has been working in public health ethics. I just didn't know how to describe it at the time. What I'd like to do today, this afternoon in a few minutes, and hopefully have some dialogue with you, is kind of talk about social determinants of health in the context of social justice, and also how the coronavirus pandemic is impacting social determinants of health and health in general. And then also want to get some thoughts from you about how does that engage, challenge, or interrupt the work that you're doing in cancer education. And one of the principles that I've learned since working in the ethics community is ethicists don't really try to answer questions. They really try to question answers. So what I'd hope for you to do in this time we're together is really question the answers, questions the thoughts. That becomes the empowering opportunity. Let me start with what I think is the microcosm of a macrocosm, and that is the coronavirus pandemic crisis. It started off in my thoughts as being a public health crisis. That is, it was impacting upon the principles and practices of public health. How do you prevent things from getting worse? How do you promote health in the context of dismays, disability, and dysfunction? And it evolved from a public health crisis to a medical crisis, which was surprising to many, but not to others. We found ourselves trying to respond to what the public health system failed to do and boiled over into the medical community. And now we're in the midst of both. So we're in a public health crisis and a medical crisis. And I would argue that really, in fact, is almost by definition, public health ethics violation. So really consider that in the context of my conversation, not your quote unquote specific activities or responsibilities, but in the context of something is wrong, something is not right, something that is should have been preventable and quite frankly is getting worse. Something that should have been preventable and quite frankly is getting worse. We hear the terms social justice, social determinants of health, and what I would suggest that really is in a line of descriptors around the same issues. Descriptors around the same issues. The Centers for Disease Control defines social determinants of health as conditions in a place where people live, learn, work, and play that affect a wide range of health risk and outcomes. These conditions, they say, are known as social determinants of health. And I would pause out of my context as an African-American man that also one of the places is where we worship, because that's in fact a really serious concern during this pandemic, where we worship, particularly for the African-American population. But in a line of what I would say different terms for the same dynamic, the same challenge, I would suggest that social determinants of health evolved out of system barriers. You know, what did the system do or not do that created a social determinants of health? Systems in education, systems in health or lack thereof, systems in employment, systems in housing, all systems in the environment, all those system barriers that result in social determinants of health. As a result of that, you find several risk markers, not risk factors, but risk markers that lead to risk factors. For example, some would argue that race, be it whatever race you may be, is a risk marker, as a risk factor for disease, disability, dysfunction, and premature death. I would argue that it is not a risk factor. It is a risk marker. You are born who you are. So you can't be born with a risk factor. You're born in a condition that creates the risk factors. So the risk markers lead to risk factors. So we can identify race as a risk marker. Race can't change. Ethnicity can't change. But social risk factors can change. Your economic circumstance, your living circumstance, your educational circumstance. So don't get risk markers confused with risk factors. I'd hate for my child or any child to be born knowing that they are by definition a risk factor. That's severely disadvantaging. And anyway, out of the risk factors come illness, sickness, and premature death. All those things, in my view, are preventable. And let's talk about that in the context of the pandemic crisis that we find ourselves. I listened very thoughtfully to the results of the polls, and not surprising given this audience, given the kind of work that you do, that you would vote largely about social determinants of health. I would also suggest that your willingness to stay in place until you know better is very wise. And I would suggest that until you know better, do what is in the best interest of the public. I know that we're hearing a lot of noise about public health or economic disparities. And I would suggest that's a false dichotomy. It's not either or, it's both and. And in my view, public health precedes all of that. So what do we know about the coronavirus pandemic? We were blessed to co-author a commentary with Dr. Ron Braithwaite, professor of community medicine at the Morehouse School of Medicine. And what we really tried to do was capture in a moment's time where we were as a country about related to the coronavirus. What we knew in the context of the historical development of African Americans, particularly because, quite frankly, we were not surprised when the data began to show that the Black population is disproportionately suffering from this pandemic. And it harkens back for me last year, 2019, when we commemorated 400 years, 1619 to 2019, when Africans were brought to this country called the Middle Passage. And that targeted the continual disparities that we talk about today. And we went from the Middle Passage, 1619, to the time of enslavement, on to eugenics movement, which really talked about being born with a difference, a measurable difference, and an inferiority, superiority difference. In England, it started off as a class difference that you were born with genetically, if you will, and evolved in the United States as a class and racial difference in the United States. So we talked about the eugenics movement, and then in the response to the eugenics movement and to enslavement and to Jim Crow and all those other challenges to this country, not just to African Americans, came the civil rights movement. And out of that came the war on poverty with President Johnson in the 60s. Out of that came the minority health movement, if you will, when in 1985, the federal government acknowledged and admitted for the first time that morbidity and mortality could be chronicled by race and ethnicity, not caused by, but chronicled by race and ethnicity. That's been the movement. And now we find ourselves with the greatest challenge in my lifetime that this country has ever known, this pandemic crisis. And I would suggest, as I said earlier, it is a microcosm to the macrocosm. There's nothing that we didn't know that we could not have predicted related to this pandemic crisis. We knew that certain populations were disadvantaged, and what they start off saying is they're disadvantaged because of pre-existing conditions, because of chronic diseases, because of all those things, and those are true. We talk about diabetes and heart disease and cancer and cirrhosis of the liver, all those things that put a population at risk. But at the same point in time, I would argue that it's not those preconditions that are the greatest challenge. It's the condition in which we find ourselves in right now, the conditions in which low-income populations, particularly African-American and Hispanic populations, have to go out and work under conditions that are a challenge to one's health, regardless of the environment. I've been blessed to be on remote travel, remote work schedule. So I'm actually in Atlanta in my house. I work in Tuskegee, and so I don't have to go out. I order my groceries. I've not left my property in 3 weeks. I don't drive my car. But those who have to come and deliver the food, those who deliver the mail, those who do those kinds of frontline services are at risk. And they were at risk before. This manifests and worsens the risk. So if you look at the folk who are in the marketplace doing the things that they have to do, not choose to do, we need to acknowledge that and thank them, and then use that as an opportunity not to belabor the past of health disparities, if you will, or social determinants of health, but those factors, those conditions that worsen the possibility. And when one is, quote unquote, diagnosed through this so-called testing process, And what happens after that? Quarantine, if you will. Quarantine where and with who? Care, if you will. Care by whom? All it does is it maximizes or makes clearer the challenges that existed before. Social determinants of health. But system barriers is the language that I would hope you would consider. System barriers, because the system barriers impact adversely on social determinants of health. So think about that as we talk about what are we going to do. If some of you saw the commentary, and we tried to capture what was happening at the time. The media published April 17, 2020, the disparity deaths from the coronavirus pandemic in key states. African Americans, 31% in Georgia, at that time had 56% of the deaths. Illinois, 14% are African American, 44% of the deaths. Kansas, 6% African American, 37% of the deaths. Louisiana, 32% African American, 65% of the deaths. Maryland, 29% African American, 49% of the deaths. Michigan, 14% African American, 47% of the deaths. Wisconsin, 8% African American, 39% of the deaths. I won't belabor these statistics, the epidemiology, because you can read that as well as I can. And what I would suggest, read it today, and quite frankly, you'll see the trend. It will change tomorrow. These data are old, April 17th. As we listen to it daily, it impacts disproportionately on the African American population. And I highlight that because that is the continual challenge for this country, how to create an equitable society regardless of race, ethnicity, economic, educational circumstances. That is our challenge. And the coronavirus pandemic highlights that in ways that are very, very challenging. Now, how does that impact on what you do? And quite frankly, you know it does. And the question is, how do you respond to what it does? In the article, we talked about Humpty Dumpty sat on the wall. Humpty Dumpty had a great fall. Now, the challenge is that when the federal leadership falls, we all fall. It is impossible for one of us to suffer, not all of us suffering. We suffer disproportionately, but we suffer. Let me suggest in my closing comments a process that we should honor. Testing. Now, be clear, testing is not the answer. Testing is the start. And we don't have universal testing. But some states are still saying testing those who are symptomatic. Test those who are symptomatic. That's in direct violation of public health practice. Test those who are symptomatic says you wait until you have the problem to find out you have the problem. No, Public Health 101 says you test before there's a problem. By definition, you screen. And you screen to be sure there's not a problem. So testing is important. Universal testing, but that is not enough. Contact tracing. This is Public Health 101. Find out who has the problem. Find out who they have contacted, who they've been in contact with, to really expand and quarantine to prevent the problem from worsening. And then treatment. Now, we don't have to talk about the coronavirus to talk about treatment in this country. We have to have healthcare as a treatment right. Healthcare as a treatment right. So we really are talking about a microcosm of the macrocosm. Now, my challenge, and I spent 20 years at CDC, very proud of my experience there. Where is CDC in the conversation? This is CDC's mission 101. And where are they in the conversation? And this is not a political conversation. This is a public health conversation. The process of identifying, investigation, preventing, and cure is what CDC does all over the world and does it best. So I will raise the question, where is CDC? What are they doing, or what are they not doing? Let me kind of end with what I tried to share when we talked before when I was at your conference. I tried to give you a kind of a new set of tools to help to articulate the challenges that we're having. As I've suggested earlier, I spent 20 plus years at CDC, spent 20 years prior to that in public health. And what I found is that I didn't have the language to operationalize what I was feeling. So let me talk about a public health ethics lens, which will allow you to begin to isolate and articulate the challenges that you're feeling. First and most importantly, I think we have to talk about the notion of justice, and that each individual has an inviolability founded on justice that even the welfare of society as a whole cannot override. Therefore, in a just society, the rights secured by justice are not subject to political bargaining and or to the calculus of social interests. Put the coronavirus in the context of social justice and see who is deciding who shall live. The folks deciding who should go to work are probably working from home or working from someplace in isolation. So those who have to bear the burden of this virus are the ones that we should be concerned about. Flip the switch. We've come to recognize and respect healthcare providers for the tremendous job that they're doing, and we honor them going into a challenge at the risk of their lives, and many have sacrificed their lives for the greater good. But let's talk about all the others who are required to sacrifice with hopes of surviving this challenge. Talk about the folks who are driving the bus, cleaning the house, cleaning the hospitals, who are delivering food. All the folks who we take for granted have no choice. And in fact, we should give them a choice. Let's talk about justice. That's how we talk about justice. And in the public health ethics context, let me give you three constructs that will help you to at least operationalize what will be, I think, a changing paradigm. The first is the context of community engagement. Many of you are engaging community, and I would suggest that outreach is an old term, short-lived term. That is, you reach out to community and give them something. Give them something. And in this environment, you don't have very much to give. So let's talk about a different paradigm as the first construct of public health ethics. Community engagement, that is, being open to talk with, listen to, in fact, those who are at greatest risk. So start off by listening and not talking. Ask the empowering question and believe the answers that you're giving. Don't try to objectify the pain that people are suffering. You may not be able to feel their pain, but you can appreciate and accept it as they articulate it. Second construct is beneficence, critical. In bioethics, they talk about benevolence, that is the intention to do good. And we all can embrace that. But beneficence is the doing good, the measurably doing good. So don't translate what you want to do into what you do. Do good beyond talking about good. And the last construct is social justice. And I define justice, and let's put that context in a population base, in the population level. So not what's good for you, but what's good for us. Not what's good for me, but what's good for us. That means there's some tension that's created with your best interest and our best interest. And in my view, our best interest should prevail. Our best interest should prevail. And let me close by talking about this quote unquote new normal, the new normal. And I would suggest that the new normal is not good enough. We don't know what it's going to be, but as long as we envision normal, then we frame it around what we were engaging now or before the pandemic was created. Normal wasn't good. Normal, certain populations historically and continue to disproportionately suffer educationally, income, health, and otherwise. So a new normal is not what we should return to. But I would suggest that we ought to return to an optimal, and that is optimal health context. And in that context, the best possible that you can achieve, your best state of aliveness, our best state of being. And I would suggest think about that in the context of emotional optimal health, intellectual optimal health, physical optimal health, social economic optimal health, and in my view, spiritual optimal health. Those are constructs that can be operationalized, translated, and I would argue that when you see those as they exist, then the pandemic crisis will no longer be a crisis. It'll be a challenge that we can collectively overcome. So let me close by saying again, I'm really, really pleased to engage, and hopefully I said something, not new probably, but something that will give you the pause to think and think again. And again, I really appreciate it, Dr. Moore, and my other colleagues in AACE and also the Urban Health Initiative. Thank you.
Thank you, Dr. Warren, for that really outstanding overview of issues related to COVID-19 that we're currently facing. You're always a wealth of knowledge as well as an inspiration. So
thank you.
Now I'd like to open the floor to any questions from people in the lounge. Feel free to either unmute yourself or to type them in and we'll try to respond. I will let you know that there are a lot of messages saying, thank you, Dr. Warren. Great presentations, wonderful work.
I'll show it to my wife and I'll make life better here.
Any questions? Well, I do have a question, Dr. Warren. In light of our hopes of developing a vaccine, how do you think we should best approach making sure that marginalized communities have equal access to that?
Yeah, my fear is not the genius of American medicine or biomedical science. My fear is that as we develop what needs to be done, the vaccine, that who's going to suffer in the process? It harkens on the U.S. Public Health Service syphilis study. So I'm concerned about who is engaged in the clinical trials and development of the vaccine, how that's communicated, and what assurances that they have that the benefits of a vaccine, if you will be available to all. There's no evidence to suggest that equity is a part of the American healthcare system. So we have to do it, but until then, let's not talk about the medical intervention, let's talk about the public health intervention, the prevention. And until the vaccine is there, we know what we must do. We must continue with the physical distancing, not the social distancing. Engage in social distancing, but let's continue the physical distancing and add to that spiritual engagement. So we need to talk to somebody, call somebody every day and tell them that you appreciate their being, not what they do, but who they are. So I think the vaccine will come, but let's not put all of our hopes in the vaccine. That's just a long-term project that will have short-term suffering.
Thank you.
So Dr. Warren, a quick question, maybe what group concerns you the most when we talk about new or exacerbated disparities? So for example, I'm thinking immigrant populations. Could you speak to sort of what groups you think are going to be most vulnerable in this new environment?
Yeah, I think that those at greatest risk have not changed over the years. So I think the Black population are at greatest risk. Now within that, you've got subsets, immigrants, of course, and others. So I think we need to look at the fundamental challenge to health and healthcare in this country, and that is a disparity based upon race and ethnicity. And the others are challenges, if you will, but they're not the major challenges as I see it. The data over the years have documented that the Black population disproportionately suffers from morbidity and mortality. So let's consider all, but let's not forget those who have suffered historically.
Are there other questions? Again, feel free to type them in as well.
Hi, Dr. Warren. I have a question. So this is Kate Ayers in Memphis, Tennessee. And so my work is in cancer education, but it takes a little bit of a different focus than most people in this group. I work primarily with schools and in the K through 12 setting, and thinking about the impact of the pandemic on both our healthcare system and highlighting a lot of those inequities that exist. It's also highlighted inequities that we know exist in the public school system. And when I think about my work in the public school system and how it intersects with healthcare and thinking about the whole child model of education, what do you view, I guess, as the role that schools can take in helping to, I don't know, alleviate or mitigate some of the impact of the pandemic on these marginalized people groups?
I think the public school system is our greatest resource, our greatest treasure, and we've got to move to protect our children in every way possible. And I think that the public school teachers, if you will, ought to be our advocates and help us to understand how to protect our children. They have to come to school. They spend most of their time in school, so we can do things like teach about social distancing in a very real way. I don't think the traditional knowledge, attitude, behavior paradigm, the Skinner paradigm for education is the most effective in the health context. Start with the health behavior you want them to assume and integrate that into the classroom activity. Talk about health in the context of mathematics, and you can talk about epidemiology and biostatistics. Talk about health behavior. I think you're at the place that we must protect the most. So keeping our children safe is most important. I'm in Tuskegee, Alabama, and the schools have been closed, and 100% of the children in Tuskegee are on free breakfast and lunch. So the superintendent of schools developed a strategy to get the food out to the children where they were. So you've got the greatest task, and I think the most rewarding as well.
I believe there's a question from Juan Luque.
Yes, good afternoon, Dr. Warren. Juan Luque from Florida A&M University. Thank you so much for your inspiring words. My question was about that special issue that you're a part of in the journal Healthcare Poor and Underserved. You talked about the role of the Black church. I saw some recent reporting that even in Chicago, the Black church wasn't really reached out to. I mean, given their network of people, providing food assistance, it seems like a real policy failure of our federal government not to involve the Black church, seeing as what we see with the health disparities. Maybe your comments on that. Thank you.
Absolutely. One of your students at the MPH program said that you all reviewed the article, Mr. Birdsong. So we're connected in many, many ways. I think the Black church as a social institution has power that is unreached, has not been touched. And we've got to separate the religiosity from the social construct of the Black church. And I think they're beginning to do that in New York in different kinds of ways. But that is one of the best places, and at the same time, one of the most challenging places. Folk go to church, and we got to figure out a new way to make that happen without the challenging consequences of the virus. So let's talk about, reach out to the faith community and get some thoughts about what they want to do, and then bring it back to the health community, and let's translate that into a reality. So tell the folks at FAM I said hello.
Thank you.
Well, again, thank you so much for this time that you spent with us, Dr. Warren. I'd just like to say that it's, as I said, it's always a pleasure to sit and hear your wisdom. And I'd also like to thank the AACE for allowing the Emory Urban Health Initiative to collaborate on this. And now I'll turn this back over to Dr. Guede.
Thank you, Dr. Moore. Thank you, everyone, for attending. This has been very insightful. And thank you, Dr. Warren, for such a passionate presentation, as always, and for giving us food for thought in terms of how we move forward to this new normal. Maybe we're not even at a new normal yet. I think there's a lot of things unraveling with the anticipation of the second wave, the third wave, the staying power of the virus. But I think as a parting word, I want to say a couple of things. Thank you, James and James Mamian and Dr. Juan Luque, Drs. James Mamian and Juan Luque, for leading the membership effort in this engagement lounge to allow us to interact and exchange ideas. This is only the second of many to come, so please tune in, suggest a topic, send an email to whoever you can reach and suggest a topic. And thank you again. As we move forward, let's think about how, two parting words, how might we be part of the solutions and avoid exacerbating the disparities that are likely to come or get worse as a result of the pandemic. So as we do our programs, let's look at who are we reaching, who are we not reaching, and what additional disparities perspectives may be introduced as a result of our solutions, which are well intended, but they may also have negative consequences. Thank you so much. Jen, any last word?
We will be sending you an evaluation or a survey about not only what you thought of this lounge, but suggestions for future topics, if you're willing to be a leader of a future topic. And also if you want to connect with the other people who are participating today, we'll send out a contact list for those who opt in to that contact list on the evaluation. So look for that.
Thank you, everyone. And thank you, Charles. Thank you, Dr. Warren. Appreciate it.
Thank you.